morning. Myself, Dr. Karthika, Senior Lecturer, Department of Pediatric and Preventive Dentistry, discussing today an important topic, the stainless steel crowns, the most commonly used semi-permanent restoration in pediatric dentistry. So the contents include introduction, types, indications, contraindications, clinical procedure, clinical modifications, complications, causes of failure, prevented SSC, all techniques, sterilization, conclusion, and references. So stainless steel crowns introduced by Humphrey are prefabricated crown forms which can be adapted to individual teeth and cemented in place to provide a definitive restoration. The composition include chromium 17 to 19%, nickel 0 to 13%, iron 67%, carbon 0.08 to 0.15%, and minor elements 4%. So based on the shape, can be basically classified into three types: untrimmed, pre-trimmed, and pre-contoured. So in case of untrimmed crowns, both trimming and contouring is not done. So a lot of chairside time is required for its fabrication. In case of pre-trimmed crowns, some amount of trimming is already done. So less amount of time will be needed for its adaptation. And pre-contoured crowns, already trimming and contouring is done. So while minimal time is required for its adaptation. Coming to the indications, indicated mainly in case of multi-surface caries where restorations cannot be done after endodontic procedures, in case of teeth with extensive wear as abandonment for space maintainers, and also in case of teeth with developmental defects. Now, the contraindications in case of allergy or hypersensitivity to metals, medically compromised conditions, and teeth approaching exfoliation within 6 to 12 months. Now, for the preoperative evaluation, we have to assess the cooperation of the patient, which is a very, very important factor for crown adaptation. And also dental age of the patient. If the patient is nearing exfoliation, there is no need for crown placement. And also education and motivation of the parent. Most of the parents are unaware of the fact that we have to place the crown after endodontic procedure. In case if the restoration fails, there are chances for reinfection of the tooth. So the parent should be advised that a crown should be placed compulsorily after endodontic procedure. So in case of preem, the stainless steel crowns are available in 6 sizes for each of the tooth. So the sizes are 2 to 7. So total of 48 crown sizes are available for the primary molars. For the permanent molars, we have 24 crown sizes in total. That is total of 6 for upper and lower, first and second permanent molars. Total 24 crown. Now coming to the armamentarium for crown preparation, we have flame-shaped or pear-shaped burrs, then needle-shaped burrs, and polishing or smoothening burrs. Now the other armamentarium includes crown seater, hand scaler or any sharp instrument, then crown and bridge scissors, number 110 hoe pliers, number 112 Able ball and socket pliers, 114 Johnson contouring pliers, 137 Gordon contouring pliers, 800 417 crimping pliers. Now wire wheels and green stones or heatless stones for polishing, loading cement, glass tub and spatula for mixing the cement, dental floss for removing the excess cement after crown placement, articulating paper for checking the occlusion after placement of the crown. So first we have to evaluate the preoperative occlusion before starting the crown preparation. We have to administer LA, and some authors recommend the use of rubber dam for preventing the chances of damage to the adjacent tooth and entanglement of burr in the adjacent areas. So placement of wedges can also be done. So care should be taken not to extrude the tooth while wedge placement, because if the tooth is extruded, it will interfere with the crown preparation. And the placement of wedges mainly serve two purposes: separating the neighboring tooth and reduce the risk of hypertonic damage to enamel of the adjacent tooth, and also depresses the gingival tissues in the rubber dam to reduce the chances of bleeding. Now coming to crown preparation, the main aims of crown preparation are to provide sufficient space for the stainless steel crown, as well as to leave sufficient tooth structure for retention of the crown. Now, the first step is occlusal reduction, which is done with a 330 burr or football diamond burr. So it is reduced by about 1 to 1.5 millimeter, maintaining the occlusal contour of the teeth or until the tooth is completely out of occlusion. If the occlusal surface is already loose due to caries, we can use the marginal ridge of the adjacent tooth as the reference point. The next step is proximal reduction. Slice the mesial and distal surfaces with a 169L burr, which is a flame-shaped burr. So near vertical reduction can be done. That is 10 to 15 degrees of taper has to be maintained, and extend the slices to the buccal and lingual line angles and hold the burr slightly at an angle to the long axis of the teeth to avoid impingement of the adjacent tooth. Now, gingival margin on the proximal surface should be in a smooth feathered edge with no ledge or shoulder present after preparation. The depth should be just through the contact and beyond any interproximal caries. Contacts must be completely opened after preparation and avoid burr damages or marks on the adjacent tooth. So coming to the buccal and lingual reduction, some authors suggested preparing the buccal and lingual walls to produce a gingivally inclined long bevel to facilitate the crown placement. But for some others, they say that we have to try the selected crown size first before carrying out the lingual reduction. And if it is required, we have to go for the buccal and lingual reduction. And some others suggest that minimal or no preparations are required unless there is a pronounced enamel convexity, which interferes with the crown placement. And a bevel of 30 to 45 degree remove the sharp cusp tips and creates a gentle slope in the occlusal third of the lingual and buccal surfaces. And the clinician should ensure that all the line angles are rounded and smooth after preparation. The crown selection can be done by 3 methods: trial and error, measuring the mesodistal dimension of the tooth space with dividers, and measuring the dimension of the contralateral tooth also. And alternatively, we can prepare preoperative study models, which can be utilized to give the details of the crown width and height. Now, prevent any chance of accidental inflation of the crown, we can attach a floss to the crown structure on the buccal aspect by special glues, which is the best method. And also we can solder a hook on the lingual aspect of the crown to which the floss is tied. Now, 3 main considerations in selecting the proper SSC is adequate mesodistal diameter should be maintained, light resistant to seating must be present, and proper occlusal height should be maintained after the crown adaptation. So size 4 and 5 are the most frequently used crown sizes. Then place the crown on the lingual side first and rotate it towards the buccal side. And in that case, we can hear a snap or a clicking sound, which makes clear that the crown is in a proper fitting. Now with the scaler, scratch around the gingival margin of the crown. It indicates the gingival line and gingival contour and portion of the crown to be removed. Then remove the crown from the upper tooth, expose the scratch line, and trim 1 millimeter below the scratch line so that when we adapt the crown again on the tooth structure, only 1 millimeter of the crown structure is into the gingival tissues. If it is above 1 millimeter, it will interfere with the periodontal tissues and lead to periodontal problems. So after trimming, the crown must be contoured and trimmed to regain the retentive contour. So this is the contouring pliers. It can be used to improve the interproximal contact area morphology as well as to modify the gingival margin contour. So contouring is mainly done on the buccal and lingual aspect to adapt the crown to the gingival contour. Now, after contouring, final close adaptation of crown is achieved by crimping the cervical area of the margin 1 millimeter circumferentially. So this is the crimping plier, and crimping is done all around the crown margins. And this is for the snug fit of the crown margins into the tooth structure to prevent any periodontal issues. During crown adaptation, examine the gingival tissues with an explorer to find out areas of poor fit. And trimming and contouring is continued until the crown fits the preparation snugly and extends 1 millimeter under the free margin of the gingival tissues. Crown finishing, the margin should be thinned, smooth, and polished. So heatless green stones can be used to remove the smooth jagged edges to create a flowing curve and to thin the margin of the crown slightly. Now check for the occlusion, check the mesial and distal contact areas. Now, according to Spedding in 1984, 2 principles are needed for optimal adaptation of the crown, that is stainless steel crown length and shape of the stainless steel crown margin. So in the first 2 figures, that is A and B, we can see that the crown length is more. So in this case, it will interfere with the periodontal health of the tooth structure. And the third case, that is in the figure C, we can see that the crown length is less. The tooth is exposed here. This will also lead to accumulation of plaque and debris on the area, which in turn lead to periodontal issues again. So the correct length of the crown is important for the proper periodontal health. And coming to the shape of the stainless steel crown margin, we can see that every gingival margin is having a specific contour. So the crown margin has to follow the contour of the tooth structure in order to maintain a good periodontal health. So we have specific shapes like stretches for your first primary molars, then smileys for your buccal surface of the second molars, frowning for your interproximal areas like that. So we have to follow that shape to bring the periodontal tissues in good health. Now crown cementation. So any of these cements can be used, and the most efficient one is resin modified GIC. So once it is seated onto the tooth structure, the crown should be maintained under pressure while the cement sets. So ask the patient to bite on the crown after placement. And excess cement is removed after setting. And Kroll said that we can remove the excess cement using an ultrasonic scaler. And from the contact areas, that is interproximal areas, it can be removed by use of a dental floss with a single knot tied on it. Now, after placement, rinse the oral cavity, and before dismissing the patient, re-examine the oral cavity. Post-insertion instructions. So patient should be instructed to avoid heavy chewing with the crown for 24 hours after placement. Instructions should be given for maintaining the oral hygiene properly, and the patient should be advised to toothbrush the area very specifically after crown placement, because if proper toothbrushing is not done, it will lead to plaque and calculus accumulation on the area, which in turn will lead to periodontal issues. And the patient should be recalled every 6 monthly for evaluation of the crown. Now coming to the clinical modifications. First is placement of adjacent stainless steel crowns. So prepare the occlusal reduction of one tooth completely before beginning the reduction of the other. And adjacent proximal areas of the tooth should be reduced more than usual. And both crowns should be trimmed, contoured, and prepared for cementation simultaneously. Adapt the seat the crown on the most distal tooth first, followed by the mesial one. Now coming to placement of SSE adjacent to the class 2 amalgam restoration. Here the crown reduction is completed first and the crown is adapted. Then we have to place matrix band and wedges. Amalgam is inserted and carved. Then crown is removed without fracturing the amalgam. Then remove the matrix band and the final carving of amalgam is done. And crown adaptation and cementation can be done after placement of the amalgam restoration. So in case of placement of adjacent SSE in areas of space loss, both the preparation should be modified to allow the teeth to be fitted with smaller sized crowns than normal. Reduction of the buccal and lingual tooth wall is carried out, and flatten the contact of the crowns using a 110 pliers before placement. In case of teeth with caries lesion extending apically to the crown margin, the original tooth morphology should be restored with either a bonded composite resin or an amalgam restoration before starting the crown preparation. And if we need, we can place a piece of band material over the area where there is apical extension and support will to the crown margin. So it will permit an adequate finish line for the crown. Now, in case of an oversized crown, suggested by Mink and Hill, we can place a V-shaped cut on the crown margin. We can remove the portion of the crown from that area, then approximate the two ends of the cut ends together, spot weld, and after that we can place the crown on the tooth structure. Vice versa, in case of an undersized crown, we can place a V-shaped cut on the crown margin, then take a piece of band material, spot weld to the area, and then we can adapt it to the tooth. Now, reverse stainless steel crowns, they are used to correct actually the lingual crossbite of maxillary incisor teeth. So it creates its own inclined plane and produces a functional contact and leverage force. So the stainless steel crown is placed in a reverse manner, produces a leverage force on the tooth, which will bring the tooth into correct occlusion. But it's difficult to check the degree of tooth movement, and little attention will be offered for stainless steel crown adaptation if the clinical crown is completely not erupted. And the opposing mandibular incisor will become mobile and uncomfortable with placement of a reverse SSC. Now coming to the advantages, it's very durable and retentive. Time for placement is fast. If we use when gingival hemorrhage or moisture is present, it's fairly inexpensive. But disadvantages, aesthetic is extremely poor. Now coming to pre-made SSC. So pre-made SSC are stainless steel or nickel chromium crowns that has an aesthetic phasing, which is mechanically or chemically bonded onto the tooth structure. It was introduced in early 1990s, and examples include nose smile, kinder crowns, and Cheng crowns. But disadvantages are adequate adaptation of the buccal margin is difficult because of thickness of the buccal area, and the crown is bulbous, so they look unnatural when compared to the adjacent tooth. And chipping of the aesthetic phasing can occur. Crown has to fit loosely because if there is a pressure, it will affect the stability of the phasing. And it is expensive, and also occlusal reduction has to be greater than for the conventional. And coming to open face SSC. On the face SSC, we place an anterior SSC on the tooth. Then we remove the label portion of the tooth, cut away the label portion of the tooth, and restore that portion with composite. So this is known as a window preparation. So advantages are aesthetic is fair, very durable and attentive. The materials are fairly inexpensive. Disadvantage is that the time for placement is long because it involves 2 steps. And also the composite facing placement may be compromised if there is gingival hemorrhage or moisture, or in cases where the patient is uncooperative. Now, Hall technique. It was a novel technique proposed by Nona Hall. Here, the crown is cemented without prior caries removal, without any tooth preparation, and without the use of any local anesthesia. So it is contraindicated if there is irreversible pulpal involvement, insufficient sound to structure to retain the crown. In case of patient uncooperation, patient at risk from bacterial endocarditis, and also parent of the child unhappy with the aesthetics. So the steps of Hall technique: assessing the tooth shape first, the contact areas and contact points and the occlusion. We have to place separators in both the proximal areas 1 week before crown placement, because we are not preparing at all the tooth structure. So in order to gain space, we have to place separators before the crown placement. Then on the day of appointment, we have to protect the airway with gauze spacers. Then proper size of the crown is selected. This is tried on the tooth structure. Then load the crown with cement. Then fitting the crown and first stage seating. Wipe the excess cement and ask the patient to bite on the tooth structure. Check the fit and second stage seating is done. And final clearance of the cement is done from the interproximal areas using floss. Check for the occlusion. So that is it. Now coming to sterilization. So a critical instrument is one which penetrates the soft tissues or bone and contact the bloodstream or other sterile tissues. So SSC fall in the category of critical instruments. And for all critical instruments that are heat stable, sterilization by steam under pressure is advocated. In the same way, for SSC, sterilization by autoclave is recommended. Now coming to the causes of failure of SSC. Recurrent caries, especially in the interproximal areas, if there is poor tooth preparation, there is poor crown adaptation or subsequent poor retention, induced ectopic eruption of the permanent first molar, improper cementation methods with lost crown or open margins, failure of the pulp treatment, crown abrasion through the occlusal surface. So to conclude, preformed metal crowns are available addition to the clinician's range of options for restoring broken down primary molar teeth. So use of a well-fitting PMC, where appropriate, could be expected to last the lifetime of the primary tooth, and in some cases permit the tooth to have a lifetime. So these are my references. Thank you all for your patient listening. Thank you.